Welcome to another episode of Health Matters with PA Lynn Szabo. What are we going to talk about today, Lynn?
We're going to talk about what you need to know in the cold and flu season in the age of RFK Jr. So a lot of changes have been going on in Health and Human Services. And instead of just going through a litany of horrors, I decided to kind of guess how I think that's going to affect us up here and give people a heads up for how things might change in the future.
You think that'll affect us in Del Norte County?
Yeah.
Okay.
I think it really will. And so I've been watching the leadership, and the people in charge, my biggest complaint is they have no medical training. So it doesn't really mean that I think they need to be providers like doctors, nurse practitioners, nurses, or PAs. I think they need to have some idea of how science works. And a health influencer is not a scientist.
Okay.
It's somebody who's spouting their opinion. So they've gutted the CDC, and they replaced the vaccine advisory or the advisory committee on immunization practices and replaced everybody there with anti-vaxxers. And there's a decreased number of people on that particular panel. It's been decreased by half. So that means every anti-vaxxer now has the voice of two people that should be telling us what to do. So they've kind of diluted science and expanded non-science. So they also, shortly after the administration, an executive order called Make America Healthy Again executive order was signed. And it's all about decreasing the resources that people have to stay healthy. So here's the big take-home message.
Okay.
Now, really bury the lead. This puts the responsibility of people to stay healthy on individuals and not on institutions to help them. Okay, decreased number of Medicaid, amount of Medicaid, decreasing services for Medicare, decreasing availability to things like testing, like ongoing research, like medications.
Okay.
And so this means, and this is kind of similar to what happened with chronic pain, is people are going to present a problem to a healthcare provider. They're going to expect input in a solution, and what they're going to get is something that they're not going to find useful.
Okay, so two things here. One, what's wrong with being personally responsible for our own health? And two, they promised there would be no cuts to Medicare and Medicaid.
Well, I don't think that's actuality in Project 2025, so I'll answer the second question first.
Okay.
So 2025 is not...
No, Project 2025 is you could go through the list and check the things off that are being implemented.
You can say all you want, but if you actually look at what's happening and read it, which was horrifying. I was one of the only providers I knew who read it.
All 900 pages?
Yep.
Wow. I did not read all 900 pages, to be honest.
It was horrible. So, there's that problem. And then the second problem is when people, as patients with a health problem, get told the responsibility for their getting better is put on them, they get really mad.
Okay.
And there's a way to say it that's not so abrupt.
Okay.
And but the realization kind of happens eventually that out of the 20 things, let's say this patient should do for problem X, only 3 of them are going to be providable by their health insurance and by their provider.
So how is it the government's responsibility if I have COPD but I won't quit smoking? Why I don't? I mean, that's kind of like their argument, isn't it? Like it should be the patient's responsibility.
Right, and I think in some cases that's really great. But in some cases, for example, weight loss, they're gonna. A lot of people come to me and tell me about every cupcake they've eaten in the last week, or every time, they went to the gym or they walked around Front Street and exercised, and they truly feel like, and I support them in this, that they're doing the best they can, but they gained 5 pounds since the last time they were in the clinic. So, being responsible for your health is a noble goal, but we almost always fall short of it because, we're human beings.
It's not even just the cupcakes. If you like here in Del Norte County, right? We kind of know our statistics that more than half of the population of the county lives in the low income category
Right.
or severely below the low income category. So access to foods that are not full of crap and calories and fat and sugar and things that are affordable it's beyond people's budgets.
It's absolutely ignored, though. That part's ignored. It's put on the. It's not that. That's what I would call a systems problem.
Okay.
And it's not recognized as a systems problem. It's kind of personalized as a bad decision. Somebody made a bad decision when they're really doing the best they can. Think
So-
about somebody who lives in Klamath.
It doesn't. Yeah, right. There's no grocery store in Klamath.
Not really.
And there's not in
very
Smith River, and there's not in Hyuchi, there's not in Gasky.
Right.
I mean, we have the Hyuchi Hamlet here, but that's not a grocery store.
Right. And, it's not like you can go there to get high quality produce. That's not their goal. Their goal is to make money with, buy stuff.
Yeah, they do have produce and they have local meat and things. But again, local meat is not the same as buying. It's far more expensive to buy
Right.
grass-fed,
Right.
grass-raised local meat. So, yeah, that makes a lot of sense. So even if it's our responsibility, if we don't have access to the things that the millionaires in Washington have access to, then it's not the same.
They have no idea what it's like to live in a rural community. Not even administrators in, say, Sacramento. Not even Santa Rosa or Redding. No idea. So this is going to, let's see. This is going to change my usual recommendations to get ready for cold and flu season. So the first one is vaccines are going to be in short supply because vaccine makers were given a last-minute directive to remove the tiny trace of mercury that helps stabilize the flu vaccine. So this trace is clinically insignificant, but
But it can't be there.
people who don't understand science are super worried because the word is mercury.
Gotcha.
And, for them, even though the trace is insignificant as far as their safety, they're revamping the whole thing. So the thought is in the clinic circles that we're not going to get the vaccine at the time we usually would get it. Now, I usually recommend people, get vaccinated around Halloween,
Okay.
especially elders, because the vaccine for the flu is good for about 6 months. And Del Norte, in my experience, clinically, Del Norte has 2 kind of bumps of flu. The
Okay.
first one's around Christmas time, and the second one is late March, early April. And so if you get your immunization at the pharmacy, let's say, in August, then your immunity isn't going to carry you through that last little spring bump.
Okay.
And so I've been recommending people get it more like Halloween because that kind of matches up with the pattern that we see here. The problem is I don't think there's going to be enough flu vaccine for the people that actually want it, which would be everybody. But so I'm kind of changing my recommendation, and I think that people should get it as soon as they can get it.
Okay. So as soon as they start arriving in August, go get it.
Yeah, go get it, which means that in order to be protected against the, spring little bump that we have in influenza, it would be a good idea to get a second one in February.
To get a second flu shot in February?
February.
Okay.
It's pretty common in the medical profession that we get 2 shots.
Okay. So
Especially those of us who are older.
okay, that makes sense.
Yeah.
So how do you feel about also getting, for those of us who are older, the pneumonia vaccine if we haven't received it yet? Would that be beneficial?
I think the pneumonia vaccine is a great idea. Now, remember, the pneumonia vaccine prevents a certain kind of really, really pathogenic pneumonia. So it's all kinds of pneumonia. I mean, that's like hundreds, maybe thousands of different kinds of pneumonia. But this one is, in particular, the one that's most likely to kill you.
Okay.
So a lot of elders get confused by that because they think if they get the pneumonia vaccine, they're never going to get pneumonia, which is not true.
Yeah, that confused me. I haven't had pneumonia since I had my pneumonia vaccine 10 years ago.
Right, right. And I've had it a couple times in my life, but mostly when I was younger.
Yeah.
So not as elder, which is interesting because I'm immunized up the yin yang for sure, but I'm also around more risk than I was when I was younger.
This is true. You do work a lot.
Yeah, I work a lot and around sick people. So, although we really shouldn't get immunized, if you want one flu shot, wait till Halloween. But if you wait till Halloween, you might have 0 flu shots. So, I think August might be a better date with a consideration of a second immunization in February.
Do you think they'll be available in February then?
No idea.
No idea.
No.
But if they are, want to get in February.
Yeah, that's what most healthcare providers do, especially like older nurses. That's what they do.
Okay, so I'm going to leave it on you to remind us at a later date
I will
to get
I'll
that
back to you on that.
second one in February.
Yeah. And remember especially that you have 24 hours after the onset of fever to start Tamiflu, which is the most common treatment for influenza. But some providers might talk you out of testing, and they might say, well, Tamiflu doesn't really do very much. Well, what it does is a big deal. It keeps you out of the hospital.
Okay.
It keeps you from dying. It might not keep you from being miserable. It might not keep you from being able to go back to work quickly. So I think that, contrary to the usual medical information, like, it's a virus, we don't treat it with antibiotics, you should, spend some time in bed, lots of fluids, vitamin C, all that kind of stuff. I think you should fire into the clinic within 2 days. I think they're going to poo-poo testing you because
Okay.
we don't have enough testing, so they're risk stratifying who's getting tested.
So isn't that rationing care? You're going to test the people you're worried about are going to die and going to leave the...
It's happening informally. Yeah.
Oh my gosh. So we're rationing care now.
I see that I don't have the data, but I'm worried about that.
I appreciate the distinction of having the data and then having anecdotally
Right.
what you see currently
Yeah,
taking place.
anecdotally, what I see is medical assistants who are always surprised when I say, well, did you get the fourplex, which is testing for 2 kinds of flu, COVID and RSV. And they're like, well, you're the only one that ever orders it in this situation. And I'm like, well, I need to diagnose. This person's asking for a diagnosis and then treatment as we have available. So I need to know what's going on.
I need to find a pen and make a note to have you be my provider.
Well, I am there on Saturdays once I get over a little surgical bump in the road. This is the reason that the acute care clinic on Saturdays exists. And call out to Dr. Gordon for taking over for me this during my surgical break.
She's amazing.
Yeah, she's lovely. So
That's actually my provider. Her and Rochelle.
I'm her PA. I'm super honored to say that.
Oh, nice. Well, that was nice of her to cover for. Is she going to cover for you the entire time you're out?
I think most of it.
Aw, that's so sweet of her to keep that going in our
We
community.
have that in common. We're both acute care providers at heart. We're treat 'em and street 'em kind of girls. We're meet people where they have the need, So,
I love that.
yeah. And I also think in terms of COVID that people should get in there and also ask for testing because there's definitely a decrease in the amount of COVID tests available to do at home and also available to do in the clinic.
All right, so COVID's still a thing.
COVID's totally a thing, and even as we speak, the fair is going on.
Yeah.
That's a super spreader event for our community.
Oh.
If the last, 3 to 5 years have been, if we can use that as data, we always have a bump of COVID after the fair.
Okay.
If we have a tiny one after 4th of July because people come into the community for the fireworks and to visit and to escape the heat, but also with the fair, stuff happens. And I think if I was in clinic this next week and maybe the week after, I'd be seeing a lot of people with COVID. But you're going to have to ask to get tested. You're going to have to ask to have tests given to you to take home. They are expensive. And even if somebody does have COVID and they're in the right treatment window, I guess I'm worried that there's not going to be Paxlovid. Because, RFK Jr., we can all send this back to him. RFK Jr. has a question about its safety. But, he's a lawyer and it took him 3 times to pass the bar. So I don't think he needs to venture
But right,
on that.
and
Unless
he
it's
has substantial brain damage. His family, his siblings have come out and publicly asked us to leave him alone because of his brain damage from having that whatever worm in his brain and the drug abuse that he's gone through.
Right.
Like, stop putting him in these situations to say crazy things. And then we have elevated him to be in charge of our health and human services.
Right. And I worry a little bit about the dysphonia that he has. Dysphonia is like vascular insufficiency. It is only a description of symptoms. So in my medical mind, I'm like, well, what's the diagnosis under that?
Yeah.
What's really going on under that?
I appreciate you clarifying that was and saw my facial expression of confusion.
Yeah. So there's something about the way he talks that's not a self-limiting problem. It's connected to something else.
Yeah.
But I don't know. I haven't looked in his medical records, and we're not supposed to diagnose people, but we do it all the time, standing in the line at Safeway. So
Yeah.
I'm allowed to wonder about his health too.
Yeah, well, I think we all do. He says some off the wall things, and then he backtracks and says he never said them. And you listen to the videos, and he's just like, "Well, I didn't say that." It's just bizarre to me.
Well, they're a little loose with the truth. So that's why we should cling to science. Science gives clarity. In my opinion. Anyway. So we're going to have a little bump of COVID, so get ready for that. I would specifically reach out to your provider and ask for home testing kits. And if you're sick or your kid is sick and you're in the clinic, ask to be tested.
Okay. So any respiratory illness, think COVID, RSV, flu, and ask for testing.
And then, there are fewer government resources to stay healthy. And I think part of this is that it might be that Paxlovid, which is the treatment for COVID,
Okay.
is not going to be as widely available as we would hope.
So we're going to see people with more permanent lung damage again.
Yeah. We're going to see that we call that sequela, so the results of an illness that has either the illness has been too difficult to treat, or somebody has turned a blind eye and people haven't gotten treatment that they needed.
Wow.
So ask for testing, ask for appropriate treatments. And the personal responsibility here that they're talking about is they expect you to have a good diet, they expect you to exercise 150 minutes a week, and they expect you to be up to date on healthcare maintenance, which includes immunizations, but weirdly.
They block the access to those, and they block the information that we can find on the internet with the things that they have removed from the government websites.
And there's also a payer thing too. My thought is, even if this stuff is more widely available than I think it's going to be, you're still going to have to pay for it. It's extremely expensive.
So it's rationing care for people who struggle financially, but it'll be available financially for those who can afford it.
Right.
So how's this not a war on poverty against the impoverished instead of the systems themselves? Sorry,
So
that's probably a
little Paul Revere, my Sybil Lovington message. Yeah, I think they're going to do that. And what's really sad, and I didn't really talk about it in my notes, but there are a lot of healthcare providers that agree with just not knowing. I mean, we're over it. We give our opinion and people hate us. So
No, that's true. You can kind of feel that when you bump into them in town.
right.
Wow. And I don't blame the frustration is there and it's real. It's the same with our school teachers. They got attacked for being lazy and not wanting to go back to the classrooms and all of the other things. And then they wonder why so many of them left the profession after COVID when the nation attacked them.
Same exact thing happened with medicine. Same exact thing.
So
It
just
was so hard in COVID to be a medical provider, to be working more than 40 hours a week because you believed your community needed that. And then to still kind of do like stupid stuff, like the activities of daily living, like stuff you have to get through because you need to eat, or you need to do banking, or you need to, settle that problem with Verizon. And you can't make everybody happy.
you can't.
So who do you No wonder doctors get nasty. Not only doctors, but PAs and NPs too.
Yeah. Well, anybody who works in the medical field, the nurses,
Right.
everybody, the CNAs, all involved with that.
Right.
Not to go too far off topic with what you were discussing earlier, in an earlier episode of Health Matters, you talked about provider burnout
Right.
and the different levels of things. And then you've also, you've talked extensively about having worked the Castro in the 80s to the AIDS epidemic when back in the day when we called it gay cancer.
Right.
What was harder for you as far as burnout wise? Was it the epidemic in the 80s or was it the COVID epidemic in the early 2020s?
Well, there's two kinds of burnout, I think. I think what burned me out in the beginning of the AIDS epidemic was my heart broke
Yeah.
because I didn't have very many patients that survived. I was really early in it, and I was taking care of some of the first people on AZT, like the first 10 people in San Francisco.
Oh, wow.
On AZT in private practice. And it was just
So it was the
a
grief.
community that embraced me and that loved me and showed me all kinds of respect and support, and I just couldn't keep them alive. So that part was hard. But I think in COVID, the burnout was that people just didn't respect what providers should be. Providers would be telling them, like, you should wear masks, you should stand 6 feet apart, and if you're sick, don't call into, don't show up at work. And it was just too much of a burden to keep oneself healthy by wearing a mask. And so that was more like anger burnout. That's probably where I could have gotten snippy with patients. And, it's not like my heart broke. It's like my intellect was enraged.
You're putting all that time, effort, and energy into somebody who's
Right.
who's going to come and tell you to your face, fix me and make me better, but I'm not going to do what it is that you're telling me to do to fix me and make me better because
Yeah.
you're stupid and I know better and I'm going to interject myself with ivermectin.
Yeah.
Got
Did
it.
it work for you guys? No, it didn't.
Yeah. Well, there's still people in our community that still do the ivermectin thing and they wonder why they're having the health problems that they're having. And it surprises me. And there's nothing you can say.
I know. It's very strange.
And then they don't tell they're going to the doctor, they're seeing specialists, they're getting tests done. I just pointedly asked, did you tell them that you're doing this with the ivermectin? They're like, no, they'll tell me to stop. And there's nothing you can do.
Like I think at COVID we became really fearful to talk to people. It's because they would turn in immediately into not a healthcare discussion, but a political tirade. And telling me to go do my research, like, are you kidding me? Yeah.
Is it really research if you're just looking for the things that support your opinion, like confirmation bias? I don't know.
Yeah, I did a Health Matters about things like confirmation bias.
I've totally hijacked your show, and I apologize, Lynn.
Yeah. So here's what RFK has brought us so far. He's brought us an out-of-control measles epidemic with multiple child deaths.
This is the second time he's done that.
Yeah, second time. Yeah.
He did it here in Tonga several years ago, and now he's done it in Texas.
Yeah, and it's spreading beyond Texas.
It is.
And he's now the national health policies are controlled by conspiracy theorists, and instead of who are using AI to reflect position papers written to, I guess, show what they think should be the truth and not really science. So they've disregarded science. There's less help from Medicaid and less guidance from the CDC for providers. And I would note, in the past, personal accountability hasn't really delivered much. I mean, all of us think back as adults when last time we went to the provider and the provider said, maybe you should start diet and exercise. Your condition would really benefit from losing 20 pounds. And then what happens? Then you go home on Facebook and you say the mean doctor said you were fat. And that's not at all what's happening. And I understand it's frustrating for people to do diet and exercise as a fundamental change in how their life works, not for 3 days, but as a fundamental change in how their life works. And then being disappointed that it didn't take them to the place they wanted to.
Gotcha.
Yeah. It's going to be hard. I don't think it bodes well for rural medicine.
It doesn't sound like it.
No. But I think the patient who advocates for themselves in a non-threatening, not polite, but just not aggressive kind of way, an assertive kind of way, is really going to be able to take care of themselves better.
So so let's just take a few minutes to talk about that. How do you advocate for yourself in an assertive way that isn't aggressive and not offensive to your provider to say, I know everything and you're stupid? Where's that line?
I don't know that I say that to people as a provider, and I don't even think it.
No, I meant the person's trying to make the provider feel stupid. I phrased that poorly. I apologize.
Okay. All right. So I think all of us we have a clinical space in between us and the patient. It helps keep objectivity there, and it also helps keep anger. So if somebody challenges what we say, we're able to, for the most part, stay calm and cool. I mean, this is in the case of mature providers, okay? I've been in the business almost 40 years.
Okay.
And one of my goals is always to try and see it from the patient's point of view. And I don't yell very much. I won't say I yell zero, but I don't yell very much. I yell when I get scared for somebody. That's
Okay.
when I start yelling. But I think all of us kind of take a step back. There's even a hand position that the nurses have taught me to deflect the anger from my heart chakra.
Okay.
I don't know if it works or not, but I do it. So it's kind of like my hands folded in a prayer and at my heart and then pointed outward toward the patient. And that supposedly keeps my soul from being affected by their anger. And so when I'm doing that, I'm trying to stay on your side, even though I'm hearing things that
Gotcha.
are dangerous or damaging.
So the heart chakra, is that data supported?
Yeah.
It's,
And if you ever go to the ER, you'll see it. The nurse is doing it all the
I
time.
gotcha. That makes sense, right? Because they talk about in different health spaces about the tapping, like on your forehead or on your shoulders,
Right.
to help yourself stay present and calm, so that
Right.
it's a mindfulness technique.
Right.
Gotcha.
Yeah, absolutely. Same with me when my hands are folded and in my lap. That's my sign that I need to be listening to this patient. So the point being of that, though, is that we have ways that we can remain objective, that
Okay.
we can not yell back at people, not make people
So
feel bad.
what's the best way for the patient to say, like, I don't feel like I'm being heard when I talk to you about this? Is it just to
Just exactly like you said it.
just to name it
Yeah.
in a respectful manner, in a polite
Right.
manner, just to
Not
say,
yelling, not demanding, not, and then usually what happens is, you don't do 100% what the patient wants. You don't do 100% what the provider would recommend. You find some peace in the middle.
gotcha.
So, yeah, so just exactly what you said is super helpful. And yelling and throwing things and swearing and trying to scare people, none of that works.
And I do know that with my provider, when it was just like, okay, this is the course of treatment, this is what we're going to do with these things. I literally was just like, well, I don't want to. And the response I got back was, well, what do you want to do? And then for me, it was like, I want to take personal responsibility. I want to try this first. And then I was not doing it it wasn't as successful as I wanted it to be.
Right.
So I just got into my chart and I said, okay, I'm not keeping my blood sugar where I need to. And then they just called in the prescription for the metformin,
Exactly.
and they were just like, okay, but we can still keep with this plan, and we'll do these
Right.
things again in 3 months to see
Right.
if you can learn those habits and those behaviors.
Super important to have a time limitation on it, because
Yeah.
what that oftentimes is, yeah, we're done, So I'm just not going to do that. And, if there's no time limitation to come around and revisit the issue, then it's not really a change.
Yeah, so we can advocate for ourselves, and our providers want us to do that and have that conversation, not the demanding, I want this and I want this medication, and
Totally.
you're not treating my condition properly, and
Yeah.
do my hormone checks when there's 10,000 hormones.
A particular provider hands a lot of grace to people. That's exactly what she says. She's from the South. Give me some grace on this, or I'm going to give you some grace on that. We'll meet again in 2 months and see what progress we've made.
Gotcha.
She's lovely. So,
Yeah. Yeah.
So-
I've been lucky.
yeah, totally. So next week, I'm not sure what I'm going to talk about. I've had this big surgery. I might talk about what I thought about my experience, and how I was told a lot to be a good patient and how I tried to carry that through. Exactly that.
That's right. We get to, that would be a very interesting conversation to have with you about going from being the caregiver to the one needing the care.
Yeah.
That's got to be very frustrating for you.
Yeah. Yeah, it has been through my life for multiple times. So.
Gotcha. Thank you so much for being here, Lynn. This is Health Matters on KFUG. If you would like to hear this episode again, you can always go to the KFUG YouTube channel, go to the playlist, and find all 7 years of Lynn's Health Matters. Thank you so very much for being here.